Okay, so we're going to go ahead and get started. I'd like to welcome everyone to this year's postgraduate course on telemedicine and surgery. Dr. Peter Slag from Germany published a paper on the necessity of telemedicine and surgery in November, in the November 1999 edition of JAMA Surgery. Subsequent developments included improvements in computer-based office visits and the emergence of patient monitoring platforms that facilitate care for remote patients. Fast forward 20 years and medicine was faced with the COVID-19 pandemic. Recent data from the Commonwealth Fund found that the COVID-19 crisis resulted in a 66% drop in outpatient visits for surgeons and a similar decline in revenue for surgical subspecialties. As part of the first package of the coronavirus aid bill, Congress set aside approximately $200 million to fund telehealth and included $100 billion to expand reimbursement options so healthcare providers can cover medical expenses or lost revenue, including the ramp up of telemedicine approaches. We believe that it is critical for the practicing surgeon to be aware of these developments so that they can understand how they impact their practices. This morning, we have an all-star cast to discuss the role of telemedicine in surgery. Dr. Franco Palca from the American College of Surgeons will present a talk on evolving policy. Dr. Lola Feyanju from Duke University School of Medicine will speak about telemedicine and disparities. Dr. Joe Sharma from Emory University will speak on the role of telemedicine in graduate medical education. And Dr. Clancy Clark will round out the presentations on what does the future hold in telemedicine. Each speaker will speak for approximately 20 minutes, and then we will take questions during the panel discussions. With that being said, I'd like to open the floor to Dr. Franco Palca.
Dr. Stewart, thank you very much. Took me a minute here to get through my share this screen. Right up there with the next most common phrase in America today, you're on mute. So as we think about this, it's really a great pleasure to join the panel today. As much as this started quite some time ago, we really didn't get started and dive into this deeply until the pandemic hit us. So I'm going to try and walk through some of the early thoughts as we come out of the pandemic about areas of policy. And I look forward to the other panelists and their comments about telemedicine and the questions, because it will actually help inform us as we go through policy. I myself have no other disclosures. And so let me proceed forward. As Dr. Stewart has suggested, COVID's really launched the interest, and we're not going back. We've changed forever. And we're finding out all sorts of new ways of modifying care models and practice models and the resources around those care models. It's actually thrown a bit of a wrench in the policy thinkers who've been spending the last 5 years, maybe even up to a decade, trying to transform the resource business model of healthcare, trying to move away from fee-for-service medicine into some alternative payment. And in the midst of all that, we've added one more thing to consider, and that's telemedicine. So they go back to the current framework of fee-for-service and say to themselves, how does this fit in? Where does it fit in? And how does it keep us on our path of transition in healthcare? And quite frankly, I don't know. They're looking at us. They want to hear from us. They want to hear from our patients. So I'll try and talk about a little bit about that. From the college's perspective, there's all sorts of resources on the website, and I'm not going to go into these. I leave this to most of your practice managers who probably do participate and look into what are the Medicare current coverages for virtual services, and what can we glean from our relationships with private payers about virtual services. Also, any ideas we can share about the various vendors, what's happening on the HIPAA side of things, and then in lessons learned, are we creating some frequently asked questions for our membership? And all of this is thinking in this PHE, the public health emergency, and then the post-PHE period, post-public health time. So we're looking at the resources, the financial resources, and the readiness for your practice to jump into this. To the actual care models, we leave that to the clinicians themselves to develop, share, and emerge. And I'm hoping to hear more and learn more from our other panelists with regard to that. I want to reflect on something we just went through, and I think it shows you how the evolution is beginning to occur. And it comes from the General Accounting Office, where we were asked in late January to attend and testify to some questions they had in just this month in February. Reaching out to specialty medicine about what's going on in this area and what's the patient experience, what's the surgeon's experience, what's good, and how is it affecting the care model, what are the resources involved, and what's bad. Most of what they are looking at is to report to Congress, to give Congress a sense of what's going on. And so the GAO is that investigatory arm that's diving into this. How do we approach it as the college? We refer to our General Surgery Coding Reimbursement Committee, which has several practicing surgeons on it, as well as a group we've gathered in a listserv, the ACS Practice Management. There's between 400 and 500 practice managers who participate, and it allows us to survey practices quickly for what's going on and the impact of various policy events. So putting these two together, we can provide information to the GAO, and they can report to the Congress as well as to CMS, which is the agency of jurisdiction. We deal with a lot of other agencies, but for now, CDC, ARC, FDA, they're not spending much of their political capital in this area. It's mostly CMS and folks like the GAO. So I want to just take some excerpts from the GAO testimony and demonstrate how they're thinking and a little bit of our response to them. And this is just the second question in a whole host of questions, but what kind of services are provided and how are they being provided? And the surgeon in the group testifying basically said the majority is audio only due to the learning curve, limits of video technology, technical glitches, other hangups that I'm sure all of you have experienced in many of these different video modalities. The practice managers say that it's heavily, supporting that same testimony, it's heavily reliant on audio testimony for reaching out to the patients. Most of it is post-op E&Ms and follow-up visits that are being applied, but they're starting to see some other changes as practices evolve, and I'm sure we'll hear more of that from our panelists. The CPT codes are basically E&Ms with minute modifiers or GT modifiers that inform the payer that this was a teleconference. And they typically involve existing problems. They're not too much into new patient, new diagnostics, but things like medication changes and some ordering and reviewing. The next question was about the location and the setting. So the GAO is interested in the resources that are involved. How are they being furnished and provided to patients in their homes, and how are the providers dealing with this themselves? Most providers from our survey group looked at their use of EHRs and computers. The surgeon testimony said to furnish most of their telehealth came from home because they were COVID restricted, and their practice can set standards and expectations of how this works in their home environment. The practice manager said that some of the clinic visits and administrative office, but at home, was also just as possible, including evenings and Saturdays, and running virtual clinics. To what extent in the business side of this are providers waiving co-pays? So the GAO interested in how this affected the overall business model and what was happening in the market around the pandemic. Most surgeons really didn't have an answer. it was all over the map, even within the GSCRC. The practice managers pretty much who run the billing services who participated, this is about 130 or so, said no participants reported that they waived copays for telehealth visits or unrelated to COVID testing. The next area dealt with providers' perceptions of the quality. And could we speak to that and the patient satisfaction and any concerns relative to providing teleservices instead of in-person services? And I think most of you probably have experienced this, but there's been more satisfaction. Patients have liked their telehealth once they got used to it. They were located oftentimes far from the surgeon's practice. They were able to avoid travel to the practice for a simple visit, and pre-op care planning could be completed virtually. There was some dissatisfaction when it came to the hands-on and the immediate aftermath of the procedure. They wanted to be in the room and have the surgeons assess them and be able to read things like body language and the routine hands-on aspects of care that could fall short, things that could fall through the cracks relying on telehealth. Jumping over to the fourth was what were the main advantages, kind of a summary question in case they were missing anything, and what really where are we going with this? Many and most of the surgeons, and particularly testifying and those in the general surgery coding and reimbursement, said that this is going to fit into practice. It's going to be a hybrid approach. There are going to be aspects of this that are going to be in person and telehealth. And it's still evolving ourselves as the clinical model and the clinical practices fit this in. It adds value and shouldn't be a replacement of face-to-face care, but just not an either or, but more of a both and. So they gave an example of a cancer patient can discuss their care plan with the surgeon with telehealth. This might not be reasonable for certain patients, but you may be able to tie in the whole family. But having that physical link to a patient as a surgeon still remains the most dominant element. The efficiency of care, the examples of virtual visits and pre-op were emphasized by almost everybody, and enjoying, though, the time that the actual procedure brought patients into the office. But again, the emphasis on the fact that you could bring in the whole family into the discussion and have everybody try to help understand who are going to help co-manage the patient for the illnesses that they have. So kind of summarizing our thoughts or our takeaways, during the pandemic, the telehealth was primarily used for E&M and particularly for existing problems. Patients were very satisfied with telehealth as an alternative to in-person care. And the example being those patients who are located far away and they can avoid travel for simple visits. Mostly within the global period. And telehealth allows patients to include their families. Those are the main points we left with the GAO. And we'll continue to talk with them as they finish their report. They'll probably have us review it and make any last comments. But furthermore, the physical link to the patient has to be maintained, and that telehealth can add value in a surgical practice, but never replace that in-person face-to-face. So it's this concept of a hybrid as we push this forward. And we continue to have those conversations, not just with the GAO, but with CMS and elements of Congress as they begin to take interest in this area. So in summary, every indication is that telehealth or telemedicine is here to stay. It's going to roll into our care models, and it needs to be placed into our resource models for appreciation by payers and government agencies. Incorporating new toolkits into the care models and resourcing it will be a challenge, but the innovation of our surgeons, I fully expect this to grow and patients to learn about the value it brings. And payers are going to have to work through this value as a resource in the various payment models, such as fee-for-service, bundled payments, and other payment models as they emerge. And then All of this must assure optimal care and at the same time maintain patient privacy is foremost wherever the care models are changing. So that's the kind of overall summary. I look forward to the panel discussion as we get there. And again, thank you for the privilege of the podium.
Thank you so much, Dr. Opalko, for that insight into policy changes associated with telemedicine. I'd next like to open the forum to Dr. Lola Feyanju from Duke University School of Medicine to speak about telemedicine and disparities. Dr. Feyanju.
Thank you for giving me the privilege of joining you all today. I have no disclosures other than the funding listed here. Before we begin, I wanted to start by defining a couple of terms that are central to the talk. First, what is a health disparity? This term has been used a lot in 2020 in the wake of the COVID-19 pandemic, but it is central to providing care for people that is equitable across the country. So health disparity is an observed intergroup difference in health screening, outcomes, and/or treatment. It's rooted in inequity or a lack of justice, and therefore it should be avoidable. In the United States, we've had an evolution of how we describe unequal care and how we describe what our goal should be around reducing inequality. Healthy People 2000, the real goal was to reduce health disparities. But over the course of the next 10 years, we thought we have to move beyond reduction to actual elimination of health disparities. We've reached the point where we don't only want to eliminate health disparities, we want to achieve health equity. That is, we don't want to just simply make care less good for some. We want to make it excellent for all. The goal being to improve the health of every individual in the United States. So if a health disparity is an observed intergroup difference that's rooted in inequity and can be avoided, what then is health equity? It is the distribution of health, resources, and outcomes according to clinical need. It is an equal opportunity to use healthcare resources that isn't determined by patient preference. But ultimately, the challenge of health equity is uniting people around a common goal of what justice looks like. We need to believe what everyone should have access to in order to provide it. Now, in 2020, our world was shaped by a viral force that has changed everything, potentially forever. Now, disparities were brought into relief by the COVID-19 pandemic after initially a misconception, I think, that the COVID-19 virus would be the great equalizer. That is, it was affecting people as different in care from those who were housing insecure to celebrities such as Tom Hanks. But in actuality, it became the great revealer. What we found over time was that disproportionately, COVID-19 was affecting non-white racial and ethnic minorities with regards to getting the disease, getting very ill from the disease, and dying of the disease. In Chicago, African Americans make up 30% of the city, and yet they had 50% of the infections and 70% of the deaths from COVID-19 back in the 2020 spring peak. Similarly, in New York City, Black and Latinx residents made up only 28 and 34% of deaths, despite making up only 22 and 29% of the population. In Massachusetts, which actually had a fairly good response to the COVID-19 pandemic, the city of Chelsea, which is 2/3 Latinx, had the highest incidence rates of COVID-19 in the entire state. And finally, our Indigenous population has been arguably the worst hit of any group in the United States by the COVID-19 pandemic, as evidenced by the fact that in the Navajo Nation in New Mexico, there is the highest rate of infection per capita. And if it were a state, it would have the highest rate of any state. And that's just what's reported. We continue to have state level differences with regards to how the epidemiology of COVID-19 is documented and followed. All but 2 states report infections by race ethnicity, which is admirable, and all but 5 states report deaths by race and ethnicity. But only 6 states report testing by race and ethnicity, which tells us that there's a lot of information we don't know. We still aren't that sure in a regional way who is most at risk for having problems from COVID-19. Now, arguably, one bright spot of the COVID-19 pandemic has been the rapid evolution and implementation of telemedicine in response to a need to mitigate exposure of individuals and exposure of healthcare professionals to those who might be infected. We have probably made a multi-decade leap in the evolution of telemedicine technology, having been forced to do so by the pandemic. As mentioned already, led to the mitigation of exposure to people who might be infected with the virus. In addition, there's some evidence that it may have actually facilitated care for people who have conditions for which there may potentially be stigma. For example, individuals with HIV and individuals with mental health illness who are able now to seek psychiatric and/or infectious disease help if they need it. In addition, telehealth has allowed for less patient time surrounding an appointment. That is, they no longer have to spend time getting to the actual appointment, paying for gas, finding parking, walking from parking to the hospital. They no longer need to take as much time off from work in order to go to an appointment. And for people who are dealing with the fact that schools and daycare have also been closed for the COVID-19 pandemic, they at least have the opportunity to go to their appointments without having to obtain additional childcare. However, there are significant pitfalls associated with telemedicine given the disparate use and access of the internet across the United States. As you can see here, internet use is lower amongst Black and Hispanic individuals as opposed to white individuals, though that has actually reached similar levels over the course of the past 3 to 4 years. As you can also see, patients in rural areas are less likely to have access to internet than those who live in urban and suburban regions. For Americans greater or equal to the age of 65, who represent only 18% of the population, telemedicine represents a questionable benefit or boon. They are the most likely to need chronic disease management that might otherwise be ignored or put aside during a pandemic when we're in crisis mode. But only 55 to 60% of these individuals have access to the internet and use it regularly. And then with regards to the extent of their internet savviness, many of them aren't able to send emails, fill out online forms, or find a website that might allow them to actually connect with their provider. And this is precisely a group who, with silent conditions that may be asymptomatic, are most likely to potentially neglect their health when there are competing obligations. In addition, we know that there are significant socioeconomic challenges and disparities with regards to access to internet use. Nearly 1 in 8 Americans, that's 12.5% of the population, lives in poverty. And these individuals have lower rates of smartphone ownership, home and broadband access, internet use, and basic digital literacy. And then finally, as I mentioned with regard to the epidemiology of COVID-19, we don't know what we don't know because there are certain groups who are at risk for disparate access who are not regularly measured and not regularly tracked. These include the hearing and vision impaired, for whom both televideo and telephone visits may be very challenging. There are dysarthric patients who have difficulty speaking as a result of having previous stroke or head and neck cancers and the subsequent local regional therapies associated with treating those diseases. Non-native English speakers will have difficulty accessing interpreters, and there may be a lot of difficulty with finding interpreters and connections that allow for deep conversation about tricky topics such as obtaining consent for complex operations. Certain patients who need visual diagnosis or postoperative evaluation may also not benefit from telemedicine. In particular, people of color with dermatologic conditions may not be able to as readily be diagnosed with conditions if what they look like on the televideo platform is not as clear as it might be in person. And then finally, patients who are served by safety net facilities, including federally qualified health centers, are more at risk to be associated with practices that were not particularly internet connected prior to the COVID-19 pandemic. These are practices that often have more limited funding and more limited options in order to upgrade their resources as well as their connectivity in order to facilitate telehealth. And as a result, when taken together, at least 1 in 4 Americans may not have the digital literacy access or skills to internet-enabled digital devices to engage in video visits. And what this means is that while the advent and promotion of telemedicine has led to increased access for some, it has actually led to decreased access for many. And the coupling of technological advances without a concomitant increase in infrastructure, as well as taking into account the disproportionate effect of COVID-19 with regard to socioeconomic status on certain groups, has led to a widening of disparities with regards to telemedicine and access. Now, rather than simply talking about the ways in which we have an unequal system, I wanted to briefly go over ways in which we can make it better. We can promote store and forward telemedicine, which means that individuals can record and then send their doctors their complaints, their issues, and physicians can respond likewise with recorded information. This at least allows for some type of video access to occur and also limits the need for broadband use because there's less strain on the system. We can proactively triage who absolutely should be seen in person and who could potentially benefit from telehealth visits. Many health systems now have targets of 30%, if not more, of their visits being telehealth. But we need to be very thoughtful as to who is actually encouraged to come in person, otherwise they are at risk for disparate care. We need to promote language congruent interactions, which would therefore allow for the elimination of interpreters for patients who are at risk for being misunderstood or their conditions not being adequately treated as a result of telemedicine usage. Text message communication in order to set up televisits is also important. Many patients with limited access do not readily get into their electronic health records using the various types of portals that are set up by health systems. We need to make patients have as easy a time as possible connecting with their physicians and logging on to any systems that might be available to them. And then finally, partnerships between hospitals and government, partnerships between hospitals and industry, as well as community organizations. One option is that hospitals can partner with industries to potentially provide IT infrastructure as well as resources to individuals, but also to community organizations. Equipping churches and community houses with internet access that is longstanding and exists beyond the COVID-19 pandemic means that some of these sites could potentially serve as trusted sources and sites of telehealth access. Therefore, individuals who don't have the ability to access their physicians at home will still have an opportunity to take advantage of the advent of advanced telemedicine. Now, to paraphrase Albert Einstein, in the midst of crisis, there is opportunity. And I hope that we can all think about ways in which to make sure that the COVID-19 pandemic, as devastating has been, does not continue to perpetuate and widen disparities that it revealed. I think we have an opportunity to actually do more for our patients and get them a very patient-centered, much more convenient approach to interacting with their physicians if there is the will and if there are the resources to make this happen. Thank you.
Thank you, Dr. Feyanju. I'd like to invite Dr. Joe Sharma of Emory University School of Medicine and the CDC to speak about telemedicine and graduate medical education. Dr. Sharma. Dr. Sharma, I think you're muted.
Well, that was bound to happen. So I'm the first guilty party of that today. I think thank you very much for this opportunity, Dr. Stewart and the Southeastern Surgical Congress, to be part of this panel with such expertise and to hear specifically about the advocacy side of this, I think is really important. To steal a line from the previous speaker, we are going to be talking a little bit about how to make lemon and lemonade in the middle of lemons. So the pandemic has been that for us, for many of us. We have also been lucky enough that the college has given this more attention, and we have a new formed telehealth work group, and I am unfortunately the chair of that work group, so I look forward to a lot of help from the panel here and from others in the audience. So we're going to be talking mostly about the GME perspective. And, from a learner perspective, this has been the year for many of us. From a teacher educator perspective, we had to come up with new paradigms. In this year of crisis, we've learned that our preparedness has been, wanting, really weak in many areas. And one of those areas for sure is the teaching paradigm or the education paradigm for us. We had not spent a lot of time shoring up that for what was a very predictable future for us. And I think luckily, We are in that phase right now that we are using this crisis to augment education for our learners. The patient perspective and others I know will be talked about in other conversations today. So I'm going to steer towards the learner. And, I think Don Berwick and group with this editorial stated it very well. This pandemic has brought into question patient safety, quality improvement, but it's also brought into question the learning system. Whether our system learns from these opportunities or whether we do not and go back to the same way of doing things. And I think the GME education, the undergraduate medical education, our own CME, all of those are part of the learning system. And so I'd like to talk a little bit about that today. This was our thought process around this pandemic, and in this was group number 3, which you can see here, standard guideline development. And that was that at Emory was a lot of the initial work that we did. And in that guideline development team, team number 7 here was specifically about telemedicine. And this was about patient care first, obviously, but not too long into it was how to deliver care to the learners that are part and parcel of our mission. Being a school of medicine, being a GME program, being also a fellowship training program, all of those things were brought into significant, I would say, evaluation and how rigorous our platforms really are. This is a situational awareness. I think everybody here is aware of it, but I do want to show it. These were the 3 surges that we have kind of faced here in Georgia, in Atlanta, and which are on the top graph there. The bottom graph there is our virtual clinic visits, and that's the term I'm using for right now. That term should be brought into question as we have this discussion today. So, we were about 700 to 800 visits prior to the pandemic. And then we suddenly went to somewhere in the March time period of 2020 to almost 4,000 visits. That number has not continued and we have come down, but as you can see, these upticks and surges have affected what we are delivering from a care standpoint. And the learner is very much part of this. So the learner's exposure to telehealth, you can see in that earlier era was minimal. Now, what does the learner have to do with all of this? We'll talk a little bit about that. This is the other part, I think, of situational awareness that we really need to be thinking through. This sector of telehealth is about $25 billion right now, and is predicted to be somewhere around $35 billion by 2025. So whether we deal with it on our end for education or for patient care, there are going to be others and with much more resources who are going to be pushing this sector. I think it will affect some of the disparity discussion that we just had and some of the advocacy discussion that we had. But this is coming. 260 plus companies identified by Becker Hospital Review. As you can see, Apple, Amazon, Google, Intel, IBM, they're all part of this. And how they will change awareness of this sector, how they will push it as an economical lever. All of those things are, I have no doubt when it's $35 billion, it'll influence what we do. And this applies to education for sure. Many of these are social media platforms, as you know, and if you don't, our residents are, a couple of decades younger to me, and they're much more savvy about this. They're super users of this type of platform. So whether we take time to do this well with some governance, some gridirons, I would say, or whether we just let the residents do it, that is up for us in our discussion today. So I think a little bit of formatting and a little bit of terminology is important in any conversation. What does it really mean to be telemedicine and telehealth, and how does that apply to the learner? Well, first of all, the learner currently is a learner, but 3 or 5 years from now, they're going to be delivering care through this modality. This modality is very large. It's the classic video conferencing that we're kind of doing right now, which image transfers also are part of this. Remote monitoring of vital ICUs and vital signs in the electronic ICU. These were things that we talked about 10 years ago, but they're reality right now. Telecardiology, teledermatology, and then what we're going to be focusing on today, medical education. The ability to monitor our patients, but ability to also deliver care and coaching potentially for our learners is all part of this conversation today. I think this will be said many times, but I think it needs to be said again. We will have accessibility issues. There will be advantages in accessibility, but there'll be some disparities. Affordability, it is cheaper. Cost-saving data already exists for this. The ability to bring in a specialist when oftentimes specialists are co-located or distant sometimes to our patient. Improvement in patient interactions, increased quality of care, staff retention, burnout has been a significant part of this last year, but it has been there in the past too, not just for the practitioner, but for the learner also. And the cons, I think, are there. There's a lot of literacy issue, disparity issues, as were mentioned by the previous speaker, reduction in in-person interactions. That's a problem. We're surgeons. We like to be hands-on. I think so. Reimbursement is TBD. The continuity of care is a significant issue here. There are liability issues, and I know many of us are dealing with licensing issues because we can't cross state line. But there's another part of this. A major part of our system, of healthcare system, still remains hard copy, whether it's home health orders, whether it's prescribing. And so how does a virtual system really interact with this is going to be an issue for the next few years. And this will affect the learner significantly. I think the other fundamental of telemedicine is, what are these terms? You know, we talk about telehealth, telemedicine, e-health, m-health. Are these all interchangeable? Probably not. They have actually very strict definitions, but they're used colloquially very loosely. So the communication around telehealth and telemedicine from our perspective, and this affects the learner significantly, is very important. M-health is specifically about smartphones and smart apps and using that technology. E-health is what we're doing today a little bit. You know, the service types are significantly different, and we do need to think a little bit about what we're trying to educate our learner. Real-time online visits is what, you know, most of what we talk about, but as was mentioned by the previous speaker, recorded and saved interactions. These are an advantage for the learner down the road also, because there can be recording. I think about an MEN patient of mine. If those interactions are minimal for me, you know, 20 to 30 times a year. For a learner, those may be once in a year or maybe not in their residency. So the ability to record some of those interactions will be an advantage. Obviously, the reminders and the long-term observation are key here. When we talk about the technological connections, there are some terms I think that are important. Most of us think of telemedicine as this synchronous thing, where we are doing things live for the patient, but the asynchronous aspect of this is significant, and I'll talk a little bit about that. The asynchronous aspect of being able to record, pass information, being able to coach, have a review of your wonderful laparoscopic case. These paradigms already exist, and then the rest of it is, you know, things that we've mentioned again. So I think the key issues that we want to talk about in the next few minutes are, does telehealth replace or augment learning for a surgical resident? This applies to the undergraduate medical education portion also, but we're going to specifically focus on GME today. Is this solely a pandemic response, or are we going to learn from what's happened in the last year and use it to augment the hybrid model, as was discussed by Dr. Opelka? What is surgical telementoring? I think its current state is rudimentary. It's been talked about since the 60s. SAGES and others have done amazing work on telementoring. We have not brought that in a holistic way for our learner. I think the aspect of active versus passive learning, most of us, you know, when we remember our surgery residency, most of it was very active learning. The didactic or the passive learning was minimal. How does telementoring or telehealth really fit into the active learning is an issue for us. And then the pitfalls. Anytime you talk about education and telehealth, there's a cost with this. It's technological, but there's also a resources cost of workflow. And I'm going to address that a little bit. And then last but not least, I'm a quality guy, so there's going to be a little bit of a checklist for the learner. You know, this is a picture from Romania from about 6 years ago, a hybrid room. There are multiple cameras, as you can see. There are multiple learners in person. There are learners that are sitting hundreds of miles away from this education that is happening. There's an ability to chat. There's an ability to ask questions. And the virtual learner is not just sitting on a screen like we are today, but is actually immersed in this environment. Is this the standard for what a graduate medical education learner or undergraduate medical education learner should have, or should it just be Zoom based? I think the hybrid is where we're headed, but not many places have these resources. We think about this, or when these resources are available in a classroom, they're available in 1 out of 5 classrooms at times. So this is going to be a major push for a lot of the education side of this, where we need this level of resources. And you can think about all those monitors present in a room. You can think about those cameras, the internet connectivity. We will need all of those things to do this right and to do this well. It's not just presenting on PowerPoint to your learner. This is one of my residents' week schedule. It is just 1 week that we picked out from about 7-8 weeks ago. Everything in green are kind of the didactic time periods. Everything in blue are the clinic time periods. Everything in the beige is the actual operating time. And there's some simulation time and cadaver detection time in there too. Most of this, which is about 8 hours out of this week, of the green has been replaced with telemedicine or telehealth or teleeducation right now. Whether it's ACCS report, whether it's the chairman's rounds, whether it's M&M, whether it's grand rounds, whether there are tumor boards, whether it's a research meeting, whether it's the Wednesday afternoon research conference. All of these are using, and we're using the Zoom platform. That is a very quick change. This was a change that was forced upon us. Some of this existed before, to tell you the truth. It wasn't just that we marched into this, but about 8 to 9 hours a week of education can easily be delivered via this. And there are advantages. If you speak to the residents, and I'll show you some data in just a minute, there are advantages in having this. The clinic interactions, you know, as you saw the clinic visit side, 20 to 25% of my clinic is virtual. If you go to the transplant realm, about 80% of their clinic is virtual now, and our learners are involved in that. So they're learning right now from patients about diseases in this virtual format. How well are they doing with this? Are they truly learning? Are they learning only a portion of it? Is to be determined. And then the operating room is not free also from telehealth, and we'll talk a little bit about that. But this is a significant amount of time that's already been converted very rapidly to telehealth in this past year. There's lots of data. Data is not lacking. Of course, the data is all actually brand new. This pandemic has forced us to look at this issue. The data that is brand new has been mostly around undergraduate medical education, although that applies to a portion of the graduate, the resident significantly. But here's some data from the residents, and this came out just about 2 weeks ago. What is the e-learning curriculum? What does it mean? This institution converted completely to an e-learning curriculum like ours has. And this is about a survey of about 31 residents, so it's not very robust, but there is some data. And as you can see, this is what the resident impressions were. And we really do need to listen to the learner as we think about what this paradigm should be. Presentation skills are different from online. Yeah, they are. 73% agreed. Virtual sessions have been more useful for my training as a resident. Disagree, about 30%. My academic performance has increased. Neutral, 50%. Online presentations help me better understand the content of the session. Mixed. Academic organization is better compared with before. Majority said yes. I find it easier to attend online sessions. Absolutely. 76% said yes. My attendance has increased. Mixed. Online sessions should continue even after the pandemic is over. A little bit of mixed, but about a little bit less than 50% agreed with that. My participation in the sessions has increased partially. The academic level of the sessions is higher. Mixed. I find it easier to see and evaluate image studies. 50% or so said agreed. It's easier to participate during online sessions, as you can see, mixed results. So again, this type of data is going to be critical. And as we think a little bit about what our education paradigms are, is it as robust as that picture where there's somebody giving it in person, where there are multiple cameras, or is it just on a very simple two-dimensional platform like Zoom? And I think we have to be really careful in continue to evaluate what the residents are really learning from this. I think there's advantage, don't get me wrong, but I think it's disparate and it's sporadic. This is our workflow for clinic, and I know Dr. Clancy is going to talk a little bit about this, but as we envision telehealth, I have the same, I was there for the initial aspect of laparoscopy. We're having the same conversation. It's a conversation over equipment. It's a conversation over personnel. It's a conversation over space. I remember those early time period of laparoscopy well, and it is the exact same conversation. Most telehealth does not integrate into the EMR. It has to. And obviously our clinic schedule, and you can see that was my clinic schedule from a couple of weeks ago. Quite a few new patients, the established patients were all done over tele. Is that going to be the paradigm? This is important for us as practitioners to establish, because the learners will have to mimic this at least for 5 or 7 years of their life. And we have not established this well. Many of our practitioners are doing it in between procedures. The learners are, I promise you, missing out on that patient interaction when it's in between procedures. Many of the places, and including ours at times, doesn't have dedicated staff and space. When you don't have that, the learner is either using it on a smartphone or using it on a laptop. That's not the same as what's pictured here. You do need this space to do this well. This is a minimal requirement, I would say, from a learner's perspective or from our perspective. It has to be robust. It has to have, you need to have dual screens. You need to be able to have large enough screens where you can see the electronic medical record and the patient interaction. Just like I was on mute, lots of issues here with speakers and headphones, and the bandwidth issue is significant. Many of our institutions were suffering with this issue even before we tried to do all of this telehealth. Most of us cannot do our telehealth. We have to come out of our institutional's computer or our digital platform. We have to do it on our own. So these are issues that apply to the learner even more. The virtual visit, it needs the screen. It needs the electronic medical record on the left side, the people who are interacting on the right side, the patient, the clinician, the MA, and the resident and the medical student. This is a proposed workflow. I think that has been used by many of the institutions. The patient has interaction with the MA or a PCC. The resident prepares for this virtual visit. The patient and the resident then have an interaction, and then the patient clinician and the resident, or the patient clinician and the clinician have this. This is a semi, duplicate of what we used to do in the past with independent conversations. But if you can easily imagine, for efficiency reasons and things like that, a couple of these steps can be eliminated, and suddenly the graduate medical, the resident becomes a very passive learner. No interaction with the patient, no ability to walk through the H&P, truly get a sense of what the patient's home is like. Those interactions can be eliminated for the resident very quickly if this workflow changes. This is just a checklist, and then I just put this for inclusiveness. I'm sure Dr. Clancy is going to talk a lot about this, so I'll leave it for him. But minimum requirements. If a learner is going to use this platform, they're going to learn from this, and they're going to learn from our patient interaction. These are some very minimal basic things that they need. I look at this picture, this painting, sorry, not picture, and I see a lot of, I never worked in an operating room like this or operating theater like this. Telemedicine lets us come back to this. The learner can actually, there is a lot of learning at the undergraduate level and the resident level that doesn't happen because they don't have access into the operating room. There was a time when for third year medical school, it was 6 months surgery and 6 months medicine. That's gone away. The surgery time period has been limited to a few weeks to a couple of months. Bringing telemedicine allows that spectator, allows that voyeur, for lack of a better term. And I think we need to bring that. I think we need to take advantage of that with telemedicine. It's not just about the doer, but it's also about those people who are watching. And I think telemedicine affords us that opportunity significantly. It's hard to have this conversation without talking about the wonderful work that SAGES and other organizations have done on tele-mentoring. The asynchronous aspect of this, which is being used in residencies, it's been used for many years. The recorded clinic visit, the recorded operative case. There's data from bariatrics and MIS already, but the recorded simulation, the cadaveric dissections, we're using all of these already. And then submitting those videos to the experts, whether it's a advanced resident or a fellow or to attending. Standardized assessment exists for this very well. It's been used by many of the programs that I've interacted with, and I think this current crisis pushes us to do this even more. And but we really need to think a little bit about the synchronous aspect of this. Can we do video conferencing pre or intra-op from a procedure for a learner, but also for the practitioner? Can we have live coaching? And this has all been demonstrated in small studies and in some centers. Confirmation of critical steps, whether we talk about identification of the nerve, whether we talk about identification of Kello's triangle, whether we talk about identification of the renal artery and the endo AAA. These can all be done and improved upon in this concept. Luckily, these standardized assessments exist. They are not just about anatomy and completion of case, but they're about efficiency and safety. These need to be brought in robustly into telementoring. And these platforms, they have a cost to them, but they do exist. You know, I think these are the issues. This idea of us sitting next to the bedside will be significantly challenged with telemedicine and telehealth. What is that hybrid world, as Dr. Opelka said? I don't know yet. This tends to be very passive. It's not immersive. The sights, the smells, the beeps, the hands, you know, the ostomy output color, the drain output color, these are missing sometimes. And when they're missing, they can have significant impact on the learner. It is unsupervised, a lot of this. If as programs, we don't take initiative into this, learners are going to be doing this. They're just going to be doing it in a haphazard way. There's significant variation in service lines. As I said, transplant at our institution is about 80% tele. My own service line is about 20%. I think the stage of the learner matters in their interaction with patients. An intern who has minimal knowledge of some of those diseases, if you throw them into an e-learning or if you throw them into a telehealth platform, their ability to adapt is dramatically different than a chief resident or a fellow or an attending. So I think we have to be conscious of that fact. Last but not least, I think we are going to be thinking about a new care model. We have been doing that for the last year. The learners are part of this, but how do they actually, how much are they learning? Are they learning the same things that we were learning? Probably not. And we have to break down our patient care into these 5 areas and look at how telehealth interacts with them, how the learners interact with this. I know there's going to be a panel discussion, and I'd be happy to take some of the questions that this has raised at that time. Thank you very much for this opportunity.
Alrighty. Thank you, Dr. Sharma. That was very insightful. So we're going to close the speaker portion of our program with a presentation by Dr. Clancy Clark from the Wake Forest University School of Medicine on the future of telemedicine in surgery. Dr. Clark.
Good morning, everyone. Thank you for inviting me to share with you, and I appreciate Dr. Stewart for the invitation. And this is my high-tech telemedicine clinic, as you can see by the paperclip holding the sign up that tells people that I'm running my telemedicine clinic. It's very high-tech. And what I'm going to talk to you today about is, you know, where do we go from here? What's the future of all this? And I have nothing to disclose. I broke this down into a lot of the topics that were already discussed, but we'll cover things like what is the definition of telemedicine today and how that's actually changing, where it fits into education, research, the entire market, health policy and reimbursement, legal implications, some emerging technologies, and then also, you know, surgeons have been doing this for a long time and what the current innovations are. And so talking about the definition of telemedicine and how that's changing, I'd like to mention that a question and something to think about is what is the most extensive and widely used telemedicine service in the United States? I'll pause to let people think about that because it's so obvious that we forget about it, and it's 911. This is telemedicine at its lowest tech. It's using a telephone. When a person needs to have CPR, the dispatcher will actually walk a person through how to do CPR. So this has been around a long time. It is what telemedicine really is. It's taking care of a patient from a long distance. Telemedicine is weird because when we hear about telemedicine, we immediately think of all these other things, such as digital health or connected health or telehealth or mHealth or these other categories of using technology to take care of your patients. But telemedicine is really right at the core of all of this. And it's not a new thing. Telemedicine has been around a long time, since they used the telegraph to send supply requests for medical supplies in the Civil War, is the farthest back we know using technology to communicate. But fire signals in Greece, they used to communicate at war times if they needed help. So it's been around a long time. 1996, Institute of Medicine defined it as use of electronic information and communication technologies, whatever that might be, to provide support healthcare from a distance. And this is what it is today. We've been talking a lot about like getting paid to do telemedicine, and the legal implications and the health policy implications, but telemedicine is happening everywhere in every different media. Most common, 90+% of telemedicine is currently via the telephone. We've been talking about video-based as the sort of best new alternative to that. SMS texting to patients via platforms or just simple texting happens. Unfortunately, open group chats within Facebook are where doctoring happens. That is telemedicine. Similarly, there's companies that provide just chat bots, robots to talk to your patient, give a diagnosis, and send a prescription in. Microblogging type things like Twitter. There are definitely doctors diagnosing patients via Twitter. Bulletin board systems, which have been around since the 60s and 70s. Most common that everyone knows about today because it's popular is Reddit. And certainly doctors are involved in diagnosing patients, unfortunately, in a public environment in that modality. And then certainly telecommunications. No one really gets excited about a fax machine, but that's long distance telemedicine. And this is the biggest central problem or opportunity for telemedicine today and into the future. It has to do with your individual bandwidth and capacity, whether that's emotional or actual technologic. Things like sound. Zoom is actually one of the great examples of how they can't manage bandwidth. I'm talking now, no one can cut me off actually. And some people can cut off, but there's actual deliberate microsecond delay. So you can't sing together, for example, on Zoom because they have streaming technology issues because they don't have enough bandwidth or they can't afford the bandwidth that would actually require simultaneous conversations or overlapping conversations. Image resolution, there's two parts to that we don't really talk about, but if you talk to any like video game person, they would tell you there's spatial and contrast. Spatial is basically pixelarity of something. Can you even see what you're seeing? So small phone, high pixels, you might be able to see something. It depends on the bandwidth. If you ever say, dang, that's fuzzy when I watch YouTube, that's because of a change in resolution. Range of motion is sort of like, what are you seeing at the time? And then the transmission speed, which is there a delay, a lag? Does it sound like you're talking underwater? And at the home, certainly in the South now with AT&T Gigafiber and G5 and all this stuff, 5G, sorry. There's certainly technology capabilities to account for all of these potential barriers. But really, in reality, our patients don't have the tech to do this. We know that. Most people are older that need doctors, and most have a phone, but they don't have a phone with a camera. And certainly they don't have a desktop with a webcam attached to it that they can use efficiently. Also, our providers don't have the tech. Most of us do have a smartphone, but often that's not well set up or suited for a video-based visit. Certainly we can talk over the phone. All of us have that technology. This is reality. This is what most people's clinic visit looks like when you talk to them on the phone or or actually video visit. They're huddled somewhere that they can fit just to see you. That's suboptimal. Most of us don't have a setup like this. This is the ideal world with backlighting and multiple monitors and a speaker and such, and your water bottle there when you get a dry mouth because you're sitting at your desk for 8 hours straight. But these are the questions I recommend everyone ask before getting into the business of telemedicine. Yes, we were forced into it because we couldn't go to the office and we couldn't see people, but now, as we know, telemedicine is an alternative to face-to-face in the right setting. And the first is, does your patient even want it? Do they consent to that telemedicine visit? Does your patient even have the capabilities? Does the patient even have the bandwidth to do this? Do you need an interpreter? And if you do need an interpreter, you can do this, but it takes a little bit more effort, and you have to understand the barriers there. And then also, can you realistically do the assessment that you need to do via that telemedicine visit? So we'll break it down. So for educational reasons, telemedicine as a part of educational programs has existed for a good amount of time, but just siloed away at specific academic medical centers. For example, Harvard and Stanford and George Washington have had longstanding curricula associated with telemedicine, where they would immerse students in how to do a telemedicine visit. We just haven't generalized that, and it's well published, and you can look that up. Can you get reimbursement for a resident participation in a telemedicine visit? That's really not clear. And then also, how do you maintain the trust of the patient when you include the resident in that conversation? Multiple times I've had residents call patients or do video visits, and then the patient hangs up thinking that I didn't want to talk to them, that I put a learner in front of me, which happens every day in clinic. Good news is that the AAMC has actual competencies around how to do a telemedicine or telehealth encounter. And I won't bore you with the domains that they go through, but certainly you can look into these references if you're looking to, how do I evaluate a program in telemedicine education? So let's talk about research opportunities. And a really recent opinion article came out in New England Journal that asked some questions. Weren't really questions, they were just statements. But I posed them as questions because each one of these is something that we, if you're interested and want to pursue research areas, these are unanswered questions, but also targets for optimal telemedicine. One is comparable. Is it comparable or safe and effective? Does it add a cost to healthcare delivery, or is it actually save money? Does it improve efficiency? Does it actually exacerbate healthcare disparities? And we'll learn about that today. I think it's a question mark. And then, do you respect, or does this type of modality respect a patient's preference? Here are some things that are around the topic of inefficiency. We know from prior research in telemedicine that's been longstanding, they've been doing this for a long time and trying to understand where it fits. It takes approximately 20 to 40 minutes for you to actually get set up for one individual visit. That's pretty challenging. It can take from 1 to 5 pre-calls to make that visit happen. Most staff are not trained or cannot do what is referred to as rooming activities. You miss out on a lot of things, like a nurse who does agenda setting or care gap closure. Like, you walk out of the office or the clinic patient's room, and then the nurse comes in to fill in some information, provide education. Staff that typically does pre-charting or penned orders for you, or even fill pended medication refills or update the history. Those things might not be happening depending on the structure of your setup. I'll make this available if people would like, but there's a series of research questions that stand out. One is, can you create a collaborative visit, meaning with multiple family members? Is that even possible? How do you convey trust over telemedicine? How do you pay your staff? If you are a provider who only does telemedicine, does that result in fragmentation of that person's care? And then how do you do the handoff? You come up with a plan during your visit. How do you share that with your office, your coworkers, so that they actually show up to their chest X-ray or CT scan that you ordered during that telemedicine visit? Some other ones are, how do you improve access to specialists? Does it really actually improve access to specialists? How does it really eliminate geographic distance? That's the whole theory behind it. Does it actually improve wait times? I don't know. And then also, there's this whole world that now can be evaluated in how do you actually incorporate in the EHR the pre and post visit tasks? How do you document those activities? This has been mentioned a couple times in different ways. What is the growth of telemedicine? And this was telemedicine before. If you talk to most hospitals, they were doing it, 76%. A survey just before COVID said that about 66% of consumers were interested in telemedicine. And there was a witnessed massive, dramatic increase in visits, their telemedicine visits, but very small proportion of all visits. In 2017, there was 6.5 per 100,000 patients were having a telemedicine visit. Then after, we had this amazing shift in April of this last year, where ambulatory visits immediately shifted to telemedicine. In Australia, 38%, the US was roughly 42%. Ontario, Canada, they saw 77% increase, but most of these, 90%, were just telephone calls. And what kind of value did we get out of that shift, 90% being telephone visits? At Wake Forest, we witnessed that same change. I'll just highlight some really interesting things that happened. Is in March, no one could access the video components within Epic because you had to have special privileges. There was only a set number of providers who were doing that. So everyone jumped to other alternative platforms. We actually ramped up and did an on-premise video streaming within Epic, which required 5 additional servers to allow for the bandwidth issue. We, by June, had templates within Epic to account for the liability components, the billing components. Not until September did we receive documentation regarding how to document and the policies around that documentation. We have shifted by this fall, we had to shift out of our 5 servers running roughly about 2,000 visits at that time per week. We didn't have the bandwidth, so we shifted to a cloud-based service. And then not even until this last December did we start distributing best practices and how to actually do these visits. The growth is tremendous. I'll skip this slide just for brevity, but they estimate within the next 7 years upwards of $400 billion business of telemedicine, of which most of that will be developing products and services around telemedicine. You know about this and you've seen it. It's existed even before this whole COVID dilemma, is that large players in the healthcare market have created virtual visits. Cleveland Clinic, Mayo Clinic are good examples, but CVS also recognized the value. And you can see here in my state, you can't do one. You can't have a little mini visit to diagnose your flu or cold via online service, but most states you can actually get a $59 visit for a doctor. In China, Shanghai, they have a little doc in a box. Literally, it's an AI machine that says like you have a diagnosis of something. If you need to talk to a real doctor, you put yourself in a booth and they link you up with a person, and that dispenser can then give you your medication right away. So there's emerging technologies out there of telemedicine here. So healthcare policy, I'll skip through this, but there's guidance throughout the world on healthcare policy, both in our local area as well as in the regional. This is something that everyone should be aware of, is that your platform you use, there's guidance by the OCR on what you can use. Most of the platforms people know about, like Doximity and Skype and WebEx are fine, but I'll highlight that people should avoid your Facebook Live, your Twitch, your TikTok as media. People have been known to do this, but those are public facing media. And what's going to happen in the future? It's probably here to stay. It certainly has been around for about 100 years, so it's probably not going to go away. The modalities probably will shift, and there'll probably be additional guidance on what modality is permissible, what indications, how far a patient needs to be, what the privacy requirements and what the documentation requirements are. So some of the legal things I'll just mention, this was highlighted before. It's state-based, and it's based on your licensure. There's no sort of standard across all states. The liability here is not clear because often we talk to patients over the phone across state lines. Prior to COVID, that would be technically called telemedicine, but it now is, if you document it under a billable event, there's question about liability and reimbursement. There is one push, which is sort of interstate medical licensure compact, which basically you pay a fee and then you then have ability to get state licenses across different states. You still have to pay and maintain licensure in each individual state that you choose to participate in. Some of the emerging technologies, I won't go way too deep in this, but this is where we are now. I think that normal medicine is sort of like the horse and carriage, and we're in the car and we're super enthusiastic about it, but it's more like this. We got that fancy car, but it's broken down half the time. And that person's galloping along, running their clinic just fine. And I know many people here probably have a clinician who says, why do that? My clinic just runs fine. And when it comes to technology and advancement in technology like telemedicine, it's all about who you're talking about. So there's opportunities for technological advancement, whether you're speaking on behalf of the patient, provider, the health system, a learner, payer, advocacy group, specialty societies, government, and regulatory. There's all different markets that can have new expansion. And to think about it, you can put it into products and services, and there's things about each that we can go into great depth about what is there, but this is emblematic of that. There's a great advancements in machine learning and artificial intelligence, and a lot of people in the marketplace dabbling and trying to find out where they can get their market share. Similarly, the Internet of Things, there's multitude of companies trying to find a market share within this space. But surgeons have been at this for a good bit of time. I will highlight that, telesurgery and the first transatlantic operation happened in 2001. The McMaster University Telesurgery Program, which has been around almost 20 years now, had this boom in the early 2000s where they were doing telerobotic surgery to remote places within Canada, operating underwater, as you can see in this picture. But that kind of has fizzled out and the interest is just not there. However, there's great emerging interest in, I want to highlight Heather Evans' program at the University of Washington, where she embarked on this a long time before telehealth popularity merged with COVID, where she was just taking pictures of wounds and having HIPAA compliant communication with patients about wound care. And that has emerged as one highlighted example of an application of data collection, store and forward type technology, where you take a picture and you send it to your doctor and get a feedback in the post-operative setting. However, telemedicine in surgery has never been really that great. Actual randomized controlled trials that have evaluated this have not been that uplifting. For example, in this study, they randomized 100 patients would go to in-person, the other half would get telemedicine, and they were able to achieve 90% of people who had a in-person visit were able to complete their visit, but only 74% actually did their telemedicine visit. And that was patients just didn't want to do it, or they had technical difficulties. Another study, which was hopeful in the Netherlands, in Sweden, Norway, correcting myself, we're looking at maybe patients don't want to come here to check their stoma after a surgery. And actually that study showed that people wanted to come back to clinic, and there was no better improvement in quality of life if patients didn't have to travel. So telemedicine does not solve all problems. I think the future, I do think that telesurgery is an opportunity, telementoring as discussed, using telemedicine to reinforce care pathways. And the AI, machine learning component certainly does have opportunity of growth. I will end with this statement, which I thought was very helpful, which is that telehealth or telemedicine can have a positive effect on patient safety and outcomes. Nevertheless, telehealth comes with risks, including exacerbating the digital divide, poor software engineering, and security breaches. Future telehealth platforms must be secure, reliable, and flexible, enough to accommodate regulatory, professional, and healthcare organizations' requirements. These platforms should be upgraded regularly. And I like the last statement, updated regularly. This is a constantly moving target. Thank you, guys.
Dr. Clark, thank you so much for that great presentation, helping us frame the future of telemedicine and surgery. I think it also inspired some questions. And so I see in the chat room that Dr. Bill Richards from Mobile, Alabama asked, how many patients can't do a Zoom meeting and I go to the phone quickly but still bill for virtual visit? What are the billing implications in the future, i.e. will we need to bill for just the phone instead of virtual, and is the ability of the patients to do video visit enable the video visit billing? And so Dr. Opalka approached that with a link. Dr. Opalka, can you go into some depth about your response to Dr. Richards?
Well, I don't want to pretend to be an expert in billing and coding. There are numerous new codes in the telehealth space for these business services. I think there's up to 100. And originally there was a breakdown that separated audio and audio video conferencing, and they were paid differently. We are currently under an executive order that allows us to appreciate the pandemic, that we are still allowed to look at telehealth audio or video the same. So if you bill one or the other, they are paid as if it is an audio video. And in addition, the government moved the payments during the pandemic from a lower rate to approach the equivalency of an in-person E&M view. Now that's not going to last when that order expires. It was just renewed, I think, for another 90 days. I may be wrong, it may be 6 months, but it has to be updated and renewed. And I don't know if that's going to be the case with the new administration. They're just starting to take their new roles on as they get approved by the Congress. But for now, you get paid as if it is a video conference and an in-person visit. Unfortunately, that's not going to last.
I would echo that statement. That so if just a patient scenario, you're on the phone with a person, you're trying to do a video visit and you can't connect. Whether you can't connect, the patient can't connect. It's absolutely right. You might convert over to a telephone visit and bill for that. That will likely change. There's immense anxiety about telephone visits being considered at the equivalent value, if we talk about value-based medicine, as the equivalency of an in-person visit because of the lack of visual capabilities and the rapport you can have with patients, all the other things that people think of for value. What is the value of that in-person visit versus the telephone visit? And the concern about additional billing or extra billing. So you call a patient, then you do another visit, another phone call, and you have 3 phone calls to review different medications and such. But currently that's true. You can bill. What's interesting is CMS has its guidelines, but a lot of payers, private payers, will pay you full in-person visit for any kind of media through which you communicate with a patient. And that's interesting. It just depends on the biller or payer, I should say.
I think the one other thing, why do you need to make the phone call? It's always important to ask that question also, Bill. I mean, I think we need assistance for some of our patients to stay on Zoom or to access it for the first time. I see it no different than the disabled patient coming to my clinic at times. They need assistance. They need a different ramp. They need ambulance support at times, transfer support at times. A significant group of our patients, my PCC does it all the time, where they spend 15 to 20 minutes way before my visit, walking them through how the setup is going to be, what the setup is. Without that resource, I would be successful maybe 50% of the time, 60% of the time in being able to complete a telehealth visit. So I think all of the regulatory side is critical, but we as institutions, are just like our nurses and MAs were helping our patients get onto the gurney or get off the gurney. We need to help some of our patients get onto Zoom.
So we have another question from our executive director, Dr. Tim Farrell. Our institution is encouraging fewer telehealth visits due to the fact that the facility fees cannot be charged in hospital-based clinics and nursing staff support is being lost. Is there a way to charge facility fees for virtual visits?
No. As far as I know, no.
This is the biggest concern that we have in telemedicine, is this, my staff work tirelessly to prep a patient, and they kind of treat it like they're still in clinic, but there's no reimbursement for that. It's a fraction of the cost. I mean, the reimbursement's a fraction. Sometimes it's a full reimbursement, but often it's not. That has been why telemedicine has been rarely adopted, even before a pandemic. Just this is the biggest problem. Now, there are models out there, fee-based models and subscription-based models, where groups will say, you have access to me as your provider via telemedicine for a fee, and are able to charge at fixed rates. But that doesn't apply when you're talking about CMS and a public payer.
Alrighty, so we have another question from the audience. I think all of the panelists alluded to the concerns that telehealth not adequately addressing physical diagnosis for patients. Are any of you aware of work being done to create outposts in low resource settings to have physician extenders go to remote locations to give physical data while doing a video visit with the physician, i.e. the EICU model?
So I am aware of some individuals, again, partnering with community organizations to identify healthcare workers in those organizations to help connect patients. And so I think that we can appreciate that even a lot of the sites of healthcare provision in rural areas are still very far from the places that people actually live. And they're not necessarily sites of trust either. So it might be that rather than thinking, okay, who in medicine can we get out there? We need to think about who's out there and how can we get them to connect the patients in their community. And those individuals could potentially, again, there's already a community health worker model that's been pioneered, but there could be more creative thought and licensing about how do we take advantage of the people power that's already available to connect people and provide the touch and the sound and the feel that we need to make adequate diagnoses.
At the I will say that at the University of Illinois Chicago Cancer Center, we have actually begun to try to understand cancer survivorship in rural areas, because we know that those patterns are very different from survivorship in urban areas. And so we have actually begun to rely on relationships, as Dr. Fanju said, with our primary care physicians who are in Will County, because they are a trusted source and they can actually provide physical examination data that might not otherwise be available for the visit.
If I could, this was some time ago, but United Healthcare had made a major investment in trying to support outreach in rural communities. And one of those examples was in the Aleutian Islands. And they created a whole host of abilities for nurses, nurse practitioners, and otherwise to examine patients on site and provide even the ability to perform ultrasound and auscultation through televideo conferencing back to the mainland from the Aleutian Islands all the way down to Washington State. So a patient could undergo perhaps a vascular exam trying to assess the viability of an extremity and help make decisions about care. Now, I don't know where that model stands today, but there was an enormous investment by the payer community in trying to provide this service.
So that's a really good example. We forget that store and forward technology of telemedicine exists every day. So a visiting nurse at the home of a patient that you discharge from the hospital, who then sends you a text message that the patient's not doing well, or forwards you their lab results that she drew at the person's house, or took a picture of the wound and sent it to you. That is telemedicine. It's happening every day. We just kind of ignore it and think that's just usual care. But that is really telemedicine. And the question is, are there specialty models where you deliberately, consciously think about that? And from like 1960 to 1980, we had NIH funded many studies, and NASA, DARPA, everyone, there was an immense interest in this, where you'd have a physician extender type person, a non-doctor, who would then evaluate the person, for example, in the space shuttle, or in a rural Native American community in like Navajo reservation, and you would touch the patient, take a picture, transport it back to a doctor at Harvard, who would then give an assessment and then talk to you back. That was happening. It was well funded. All those projects are mostly defunct. The last one kind of ended back in like the late 80s. And it just was a problem of like the setup, the maintenance, the training. And at that time, I think a lot of it had to do with bandwidth of technology. But it's been well established, well funded, and well evaluated. You can do it. It's just, what's the use case and why do you need it? Now, where do we see it today? Stroke evaluation. That's where it's done most often. In rural communities, there are providers who do stroke assessments over the phone. And probably at each one of our hospitals, you know about psychiatry doesn't go to the ED. They call into the ED to do their assessment to determine disposition for the patient, and that's telemedicine. So probably all of our hospitals actually have this, where there's a provider that does an assessment in person, and then they connect with an expert somewhere else, and that's a clinician to clinician or provider to provider communication that is part of telemedicine. We just don't really acknowledge these as reality, but they're happening every day in our hospitals.
Yeah, great. Thank you so much, Dr. Clark. We have a question from Dr. Zervos from ECU. Can you foresee incentives for telehealth visits for payers or institutions as we move into shared savings models?
Well, they're already there. It's a great question, but the way the payers are moving into shared savings models is to package everything into bundles of care. And they really don't care how you deliver the care. It's up to you. And if your care model provides adequate quality and the right outcomes, and you can do it more effectively than the expected payment, you'll end up with shared savings. So if that is a model where in-person visits are reducing your overall expenditure and you're still coming up with the same outcome, be it a telehealth service being added instead, you will appreciate shared savings in those models. And those already exist in multiple specialties. So surgery is no exception.
Great. I would like to thank the audience for your active participation in this very important panel. I'd also like to thank our panelists for dropping some knowledge about telemedicine and surgery, and really helping us think about how we can expand our horizons at our institutions. Again, thank you for all. Let's see, Jill has left a note. Please claim your CME credits by March 20th, and she's left a link to claim those credits for 1.75 CME hours. All right, thank you all, and have a good rest of your weekend. Take care. Bye-bye.
Thank you, John. Great job.
Bye-bye.